Good afternoon and welcome to HealthSystemCIO.com's All-Stars panel, Enhancing the Patient Payment Process to Facilitate Collections and Bolster the Revenue Cycle, a webinar tweet chat combo from HealthSystemCIO.com sponsored by AxiaMed. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can view the tweet chat in the Media Viewer panel on the right-hand side of your screen. Other WebEx panels we're going to be using today will be the Q&A panel. You can use that to submit a question at any time, and we will take those questions later in the program. And you can download the deck by using the URL on your screen. It's been sent out in the chat box, and it's also at the bottom of some of our slides. Just so you see how we're going to spend our time today, first we're going to get an introduction to our topic by Dan Berger, National Director of Healthcare with Axia Technologies. Then we're going to have our panel discussion, which is going to include Dan, and also include Sharlene Seidman, Executive Director of Corporate Business Services with Yale New Haven Health System, and Art Ream, Director of Applications and Chief Information Security Officer with the Cambridge Health Alliance. And then we will have our Q&A. So at this point, I'm going to turn it over to Dan Berger for an overview of our topic today. Dan?
Thank you, Anthony. And again, my name is Dan Berger. I'm the Director of Healthcare here at Axia Technologies. I'm also the Director of Sales of AxiaMed. AxiaMed is the developer of a product platform called Payment Fusion, which is a PCI-validated point-to-point encryption payment solution that we integrate with independent software vendors, for example, like Experian Health, and we sell on to healthcare systems and practices. And so we're going to talk today about patient payments and the dramatic changes and impact it's had on the healthcare industry. Healthcare payments, patients today in healthcare bear a greater % of the monetary responsibility for their healthcare costs than ever before. And that's a result of rising healthcare costs, which have led to higher deductible health plans, increased copays, and more out-of-pocket expenses. And just so you get kind of a sense for the scale of that, let me get to the next slide here. So we didn't coin this phrase, but I think it's an applicable one. The patient is the new payer. What we've seen in the last year has been a 29.4% increase in deductible and out-of-pocket maximum cost to patients. That's year over year. Today, a typical consumer is responsible for roughly $1,800 in deductible payments and over $4,000 in out-of-pocket expenses. Now, note that some estimate that total annual patient responsibility is now over $10,000. And 92% of hospitals surveyed report their traditional collection solutions are negatively impacting their profit margins. In fact, there today are millions of dollars in unpaid medical bills. The consumerization of healthcare is well underway. I like to say there's no more writing checks and licking envelopes. In the first 6 months of 2017, 62% of medical bills were paid online. 95% of patients said they would pay online if they were given the option. And an amazing 89% of provider financial administrators expect healthcare payments to be made on phones and or mobile devices by the end of 2018. It's important to note that patients paying their bills is now an important part of overall patient care. So this slide's entitled Patient Care Now Extends to Financial Engagement. A stunning statistic from this Black Book report is that under top healthcare customer satisfaction metrics, as you'd expect, the number one satisfaction metric for his quality of care. But number two is now the billing experience. So the patient's interaction regarding their amounts owed post-care is now the second most important element of their customer satisfaction. 71% of patients said that mobile pay and billing alerts improved their satisfaction with the overall health provider. And that raises a very interesting aspect of this overall problem, which is that it's a relatively new thing for most healthcare staff to be communicating with patients about their financial accountability. So it involves not only training, but also a kind of a shift in mindset as people who are kind of unaccustomed to asking for payment now are engaging with patients and having a really direct impact on their overall satisfaction with their healthcare. I'll switch it now back to Anthony, and I'll join in the main conversation. Thanks, Anthony.
Excellent. Thank you very much for laying the groundwork for us, Dan. And let's jump into our discussion now. So, Sharlene, you want to start us off by giving us an overview of your organization and role, please?
Certainly. Thanks, everyone. My name is Sharlene Seidman. I am the Executive Director of Corporate Business Services for our revenue cycle here at Yale New Haven Health. We are a large health system in the Northeast. We have 5 hospitals and 1 large physician organization. And most of our hospitals are in Connecticut. We have 1 in Rhode Island. Our physician practice is a multi-specialty group practice of approximately 1,000 physicians. And we have about $4.3 billion in revenue a year.
Excellent, excellent. Thank you, Sharlene. Art?
Hi, my name is Arthur Ream. I'm the Chief Information Security Officer of Cambridge Health Alliance and the Senior Director of IT Applications. We are a 3-hospital system in the greater Boston area, namely Cambridge, Whidden, and Somerville areas, with a Public Health Commission for the City of Cambridge as well, which makes us a quasi-public, private, nonprofit, and any other corporation you want to put us into institution. We are affiliated with Beth Israel Deaconesses and ACO and Harvard and Tufts Medical Schools for teaching hospitals. We have around 140,000 patients in that general metro area. NCQA Hospital, HIMSS level 6 and 7, 6 for inpatient and 7 for ambulatory.
All right, very good, Art. Thank you for that. All right, let's get into it. Art, why don't you start us off here? Changing dynamics. Talk about the changing dynamics in the world of patient payments.
Yeah, I think we're all challenged by the patient payment dynamics. Like mentioned by our previous presenter there, it's becoming one of the more, or the second driving factor in patient experience of care, and because we're all concerned with our financial aspects of it, and being able to see your billing online is becoming even more prevalent now. I think a lot of institutions struggle with the fact of trying to produce a single billing office, 1 patient, 1 bill for both professional and hospital side billing, and seeing their co-pays rolled up according to their coverage on a real-time metrics inside the hospital. So that's really we deal with that aspect of it, and also presenting to the patient a very secure environment to make that payment, because we've got to deal with, from healthcare institutions, the PCI, the payment card industry standards, and then the vendors and applications that we have to actually sit under from a security standpoint. That's a real large undertaking for a lot of institutions who not only have patient-based stuff, but external programs that they're offering, such as wellness programs, yoga, all these other things which you actually sponsor, but they may take a different payment option. So that's an overhead for the IT department and the fiscal departments to manage the security around that. So it's a real big patient experience of care, and it almost equals the actual care that they're getting at an institution. because they treat it and value it that much.
Wow. Sharlene?
So I can echo some of those comments and what Dan mentioned earlier about the patient being one of our top payers now. We used to look at and analyze by payer our industry, what's happening, and identified maybe 10 payers out there that we would have to deal with to collect. Now we say that our payer market has increased to 3 million in size because our patients are now our payers as well. And the shift to a patient becoming a consumer has become a reality for us, especially in the last couple of years. And so any of the approaches that we're taking to capturing as well as retaining our patients, because we are now viewing them as consumers, is at the top of our mind and part of our strategic plan for this year especially.
Very good. Dan, anything you want to add?
I think I'd like to also just echo those comments about how important it is to the patient. The whole billing experience becoming really an extension of their care. There's a number of challenges that we can get into, and I'll be happy to talk more about those then.
Very good, very good. All right, how is your organization dealing with the changing dynamics that we just discussed, and what made you realize new approaches were required? Sharlene?
Sure. So our patients are really almost equally concerned with getting better as they are with how am I going to be able to pay for this. When the shift occurred, really we started feeling the impact about 5 years ago, where patients who have high deductibles and higher out-of-pocket expenses started realizing, wow, my insurance doesn't pay for everything. I'm now being billed, and this is the way it's going to be going forward. We started hearing more and more from our patients questions on what can I expect my bill to be if I'm going to have this service. So one of the things that we've had to deal with is estimating those costs. And when we first started doing this and providing estimates to patients, it was really difficult. And because we were trying to predict exactly what services the patient was going to have, we were trying to get information from the patient's insurers and benefit coverage to give them a real good estimate. Both of those things have improved drastically in the last, I'd say, really year, where we're able to give patients better estimates. But we realized that we needed good tools to do that. So we've been relying on a couple of our technology partners to help us and give us those tools. The other thing we've been doing is engaging we have a patient and family advisory group, and we've been utilizing those patients who use our health system, know how to navigate in our health system, and may have had a less than stellar experience. So we bounce any of our ideas off of the group and get real feedback from them. You know, one of the things we thought was, as people who work and are professionals in this industry, we have all the answers. We know exactly what to design. And guess what? Our patients were sometimes telling us, you're wrong, and you should listen to me. So that has helped us out tremendously, and so those are some of the things that we've been working to make better.
Sharlene, have insurers gotten better or more cooperative with being able to handle those questions about what is this going to cost? I mean, in the past, did we not have representatives, or at least some of the lower level reps who'd get on the phone saying, well, I don't have that information, the bill's got to come through. You know, yeah. we can't tell you until it's over.
Yes. So it has gotten better. So a couple things have improved there. The representatives from insurance carriers are catching up, just like our staff is catching up and understanding, because it's extremely complicated once you start to understand your benefits. We have employees who are part of our health system who don't really know the details of your benefit plan design until you need to receive services and you start working through it. The same is happening with the insurance carriers, but we're trying to rely less and less on those phone calls and using electronic methods to obtain that information. So through RTE, which is real-time eligibility transactions, we're going out, pinging insurance carrier system, bringing that information back electronically and automatically into our system and breaking it down into its components, saying what is the deductible, what is the out-of-pocket max, how much has already been met, and that has gotten tremendously better in the last several years.
Art, it's a complicated process, as I think you'll agree, and Sharlene touched on the idea that we need to know what's going to be done clinically. And you can, can you get into a situation where someone's getting something done in the operating room and it deviates from what, the planned bill was? The doctor's not going to sit there while the patient's unconscious and try and figure out the additional costs and then wake them up or speak to a family member and say, hey, do you want to go for this? So anyway, it gets kind of crazy. I know that's kind of silly, but your thoughts on that or some of the things Sharlene touched on?
Yeah, I think some of the, the dynamics of healthcare, much to what Sharlene said, is the people that are sitting there doing the registrations or doing the prior auths or the ABNs or something like that is going on what the procedure is going to be and the costs around that. And hopefully our electronic industry from both the insurance and the provider side are in relative sync. I think that's a challenge, but when they go forward and make the decisions clinically, like you just mentioned, which, I don't know if it's that far-fetched that doesn't happen that often. I'm willing to say that it probably does happen. I think the challenge is, frankly, after the fact, that I don't believe that other than the clinical description and what happened and what changed during that procedure to the family members, I don't think we do a really good job yet of following up and saying, okay, you went in for this, I found this, we had to do this while we were there. Here is the implication of that from a financial standpoint. So there's really that post-financial follow-up after the fact that we don't really do a real good job with, in my opinion, across the board in healthcare right now. Somebody coming in and saying, look, these are the options and these are what we can do. And I think we need to get better at that, and that's definitely a patient experience of care. The next thing they know, they're seeing their bill online into their portal, and they're going, oh, geez, what do I do about this now? You didn't explain that to me. I think we get into that situation. And feel free to disagree with me if you don't.
No, I'm going to let Dan jump in here, but, it makes you think of, if you're getting something done on your house, you get an estimate, and then if the contractor finds something they didn't expect, they run that by you, and you get an opportunity to decide if you want to incur those additional costs. It doesn't happen sometimes in healthcare, and you may have a patient that says, well, that wasn't what I agreed to. Dan, you touch on anything that we've been discussing, please.
Yeah, so what I think is a really important point, because if you think about the situation we were describing, the patient undergoes some sort of surgery and there's something changes and suddenly there's a whole lot of other additional procedures being done without the possibility of them really knowing or approving what the additional expense will be. So now you've got the scenario where the patient is recovering from obviously a stressful event, traumatic event, and they let's go back to the kind of old school. They get a bill in the mail, and the bill in the mail is say $20,000, instead of what they thought was maybe going to be $3,000. Now you've got a stressed out patient who's recovering, and when they look at that bill that comes, their tendency is they're not going to want to deal with it. That's basically what their attitude is, and so they bottom drawer that bill, and it's very difficult to get them to pay that, and it's very hard. It's very delicate to follow up to ask them to pay for it. So one of the things we've seen that has really helped that this whole situation, and it's not just the underestimation problem, but it's just the kind of bills in general as healthcare costs have risen, is that providers are now reaching out to patients and offering payment plans. So, you know, instead of that $20,000 bill being, you know, just something that the patient could never dream of being able to afford right away, they come back and say, hey, you know, this is what you owe, but, you know, we could set up an installment plan and you could pay over time. And just letting the patient know that that's an option and kind of being proactive about it is goes a long way to improving the patient experience. There are also maybe some charity possibilities involved where certain people who just can't afford it can apply for charity applications. So, you know, I think that's one way of dealing with that kind of, you know, underestimation. It all kind of comes back to how the provider reaches out for payment and kind of how they approach it. Because on the provider side, that's a large amount of money to be outstanding as well.
Yeah,
and I think.
Oh, go ahead.
And I think just, you know, much to everybody's point at this point, there is a larger organizational movement across the United States called direct primary care that we will soon to see some competition in. You know, it's primarily a concierge health service, but we're seeing these crop up in the Boston area where physicians are doing, you know, carrier catastrophic to handle the, you know, our hospital side of stuff, but, you know, give me $2,000 a year and I'll provide you X, Y, Z. And, you know, the direct primary care movement is moving everything, you know, starting to be more user and patient friendly and more, you know, service orientated than the health systems are at this point. So we do have a competition that's ramping up there that I think will be significant over the next 10 years.
Sharlene?
Yeah, I was just going to add to what Dan was mentioning about the payment plans. The majority of our self-pay receivable is comprised of patients who have initiated a payment plan on our side, but it's all retrospective. And what Dan is suggesting is do something proactively. So when you send that first bill out to a patient, set up the payment plan criteria or guidelines up front, and that's what we're going to be attempting on our side to do. And we think that we'll get movement and establishment of those much sooner.
Yeah, Sharlene, if we're moving into an accountable care world where we're getting paid not to do things to patients but to keep them healthy, right? Dan talked about the idea of getting a bill for $20,000 when you expected to pay $2,000 after a traumatic surgery or whatever. Every surgery is traumatic. Point being that somebody may throw it in the bottom drawer and not worry about it, but a lot of people are going to panic. And for a lot of people, that panic and stress is going to negatively affect their chances for recovery, for a positive outcome. And then that's back on the health system in the new accountable care world. So you're almost really helping yourself by trying to remove that stressful event from the patient. Does that make sense?
Makes complete sense. And so what we all need to think about, and one thing we've done to react to that is creating as much upfront communication and education with the patient as possible so that when they get the bill, they're not in total sticker shock by the amount, because it's extremely expensive in the healthcare world. And so what we're doing is we're either sending out estimates ahead of time or calling the patient and letting them know that I understand you're coming in, you're scheduled for a service with our health system. I'd like to talk to you about what you can expect, what you might be billed, and so that they're not in total shock.
Very good, very good. Art, let me throw something by you. It's kind of similar to what we were talking about, but you have, so this could go under the heading of getting a bill you didn't expect, but it may be a different flavor of it. The idea that a lot of times when you're in a hospital, people are coming in and out of your room doing things to you, or in the OR, people are coming in and out, and all of a sudden you get a bill for someone who's out of network. You never met them, you never agreed to be treated by them, you have no idea who they are, but they're on your bill and they're out of network. Does that happen a lot, and is that fall under our discussion here?
Well, I think it does happen in a reasonable amount of times. That while we try to keep the providers in network, the consultations, you try to keep it in network or in your ACO as far as your consultations, but at some point in time you're going to encounter that, and then they're going to get out of network. It's not covered by that, that insurance, or is not a provider that's enrolled. And at the time of the consultation or that part of the treatment plan, you may not be able to ask the patient that, and you would not necessarily be checking that on a provider level and that engagement. So I do think it happens. How much, I'm not all that, sure of.
Sharlene, any thoughts on that?
Well, I think that it's important that the health system recognize that that can happen. We try to have as many providers, I think anesthesiologists is a great example, who are participating with the same plan, because I think it's unfair to expect the patient to ask, is my anesthesiologist or is my radiologist who's going to read this exam, are they participating? Patients just don't know that. So I think it's our responsibility to fix that.
And Dan, again, is that just another area that, well, I guess you want to get ahead of that as a health system, make sure that doesn't happen, but just your thoughts on that dynamic.
Yeah, I think it's another example of of a potential unexpected charge. That is I guess communications is the key. As Sharlene said, as much education up front as possible. This may happen. This could occur. We may need to involve somebody else that's not currently in network. As much as that upfront communication, and again, it's a really different paradigm than the way we delivered care in the past. Having that level of detailed discussion.
Very good. Dan, let's stick with you on this. The challenges associated with solving the current payment issues, obviously, you've got a solution at Axia, but talk about the challenges of getting your arms around this.
Right. So the challenges are enormous. If you think about it, everything we've been talking about is effectively facilitating patient payments. The majority of that facilitation revolves around accepting payment cards. And the complexity of managing the card processing environment right now has radically changed in healthcare organizations. If you can remember the days where really credit cards being accepted at hospitals were limited to the cafeterias and gift shops. But it's absolutely a necessity right now for all healthcare providers to accept credit cards, both at point of care, online, via mobile devices. You can extend the geographic or the footprint of those devices across a hospital system to affiliated ambulatory clinics, pharmacy point of sale terminals, labs, specialist MD offices. But if you're implementing some of the things we talked about of like payment plans or reminders, then you want to offer the ability to make those payments from within different software applications. So ensuring effective security and full PCI compliance requires a careful coordination across multiple functional departments and often involves multiple third-party vendors.
Very good. Art?
Yeah, the payment card industry, you have probably, like you mentioned, it changed in 2015 to be the least common denominator in the technology is responsible for a breach. And if you're still on mag type readers and you've now got a breach that's Bank of America and they need to reissue all the cards, you own that breach along with the costs associated with it. So I think we're challenged in that respect, not to mention that the disparate number of systems, like I mentioned earlier, like wellness programs and stuff like that, you're collecting them on Square, at the yoga program on somebody's iPhone. So how do you deal with that? The regulation from a security standpoint, and then the PCI regulations and certifications in general. There's about 15 levels to that. So when you start to get into that, do you store the credit card? Do you do the education about on the credit cards and how, what should the device look like on the, there's so much to that. You could almost create your own department to manage that in any given healthcare. And then do you store anything on site, or do you have a third party that's your clearinghouse? So is your clearinghouse, and it just goes on and on. So it is a complicated world for the security individual at any given institution, not to mention IT. And then, operations. In patient financial services and stuff like that, they have to spend, yearly money on education material from an online learning module and stuff like that to, to prove that you did do your due diligence in your education of how to handle cards, how to do processing. And then if you do manually keying, you got to educate one way. If you do swipes, you got to enter one way. And if you do telephone or faxing. So there's a lot to keep a track of. And then, I have about 7 payment clearinghouses here that we use, not just for, for different services. Each one of them wants you to go certify annually. They want you to go down through the questionnaire, or they fine you, and attest to your actual certification of your environment.
Not
complicated
easy.
World, sorry.
Yeah. Sharlene?
I don't think I have anything further to add. I feel like I'm in a lucky situation where I have a security and treasury group here who specializes and does the heavy lifting. I can tell you that we've had to add resources to this function, and because it's become such a huge emphasis. We're trying to also standardize how many clearinghouses we use and lockbox services, so I think that may help a little bit.
Right, right. Does that mean you can't or would not want to accept every possible payment alternative out there, that you want to streamline it?
No. From the patient perspective, we do accept all forms of payment, although we're not doing things like PayPal or Venmo yet. We haven't moved into that arena, but this is more consolidation on the banking and the credit card vendors, the clearinghouses. Right.
Yeah, you basically, you have to move to how they want to pay, right? And if PayPal and Venmo, if that's how people want to pay, you have to be able to take the money and whatever. If someone's willing to give you money, you have to be able to take it, right?
That's right.
That's where we're going.
Exactly, right. And the how they want to pay. More and more of our patients want to do everything with their thumbs and their fingers on their mobile device.
Right.
And so we need to move. We're not there yet, but we need to also move toward the mobile device technology for patients, which includes all of those options.
Dan, it's interesting. It's like you can almost make it a rule of thumb. Just follow the most cutting-edge retail methods out there and you'll be okay. That's where you need to go. And I'm thinking specifically of a lot of the food places or a place like Starbucks, right? You order online, you hit a few buttons on your phone or just repeat your last order. It comes off your credit card, you go pick it up. People they want that simplicity of the leading edge retail places and food places, and they want that everywhere, and they're stunned, and if they almost say to themselves, well, if you can't accept it, I'm not giving you any money. You change.
Yeah, there's no doubt that all healthcare organizations have to adapt to facilitate patient payments by allowing the multiple forms of payment and by letting them pay the way they want to pay. And as Sharlene said, it's evolving very, very quickly to online, to mobile, to other types of payments that are not not card present. The one thing I would like to stress here, and just I'll put a little plug in for AxiaMed, but also more importantly, for the point of care collections, there is a kind of gold standard now of accepting credit card payments on a point of sale or point of care basis, and it's called PCI validated point-to-point encryption. So effectively, the card is still dipped or swiped at a payment terminal and immediately encrypted, and then sent to the, in our case, it's sent to a cloud app so that it's not, there's nothing stored locally in terms of the card number. In addition, qualifying for PCI validated point-to-point encryption requires you to have follow a rigorous set of controls in regard to the chain of custody of the payment terminal and the encryption keys as they make their way through the provisioning process and out to the client. So, at least at the point of sale or point of care, there is something we can all strive towards now, which is very good security. So I just want to put that point out there, because there are, one of the ways that we like to address the overall problem is in situations where you can collect money up front for valid reasons, whether that's copay or estimations or whatever. Oftentimes that may be at point of care, even post-care, because it may be a return visit to the doctor's office, and there's certain applications that can engage the patient to make a payment at that point as well.
Very good. Art, let's go with you on this one. Talk about the security aspects of accepting patient payment in different ways, if you haven't already touched on everything. Any other thoughts with this?
Sure. I mean, the patients, like we've mentioned earlier and the panels mentioned earlier, more and more moving towards the mobile apps. So you've got everybody who wants to use some brand of mobile payment that's, on their phone that interacts with your systems, and that you present a payment portal, which again, runs into, what was previously mentioned, I believe by Dan, is that you've now got this robust, security infrastructure that you have to go down and manage, which a lot of us, don't have huge departments that do that. So there's a challenge from an infrastructure there, but maintaining that security and that processing tends to be an overhead for an organization into either an IT department or Sharlene's area, who has a larger group that looks down through and manages that, is the ultimate thing to have. I mean, it's always got to be on your forefront of your mind. It's their identity just as much as their health care. And, if they get breached or their bank accounts or something happens to them, that's not, regardless of their health care and everything, that impacts their ability to take care of their family and your reputation. So there's, tangible and non-tangible cost to that. So it should be treated almost like the security of it, like you're, taking care of their health care needs, because it is that important at this point in time in today's society. I mean, that can be devastating for any given family. So yeah. It's a serious thing to consider and factor into your overall plan of how you're going to do patient experience of care, payment, and reimbursement.
We certainly don't want somebody getting a larger bill than they expected in some of the scenarios we covered, and then attempting to pay and having a breach and having all their money stolen that way. Right? That's a worst case scenario.
A bad scenario.
The double whammy.
I wouldn't go back to that hospital, so let's try and avoid that. Sharlene, let me touch on, let me go to you for the next question. Which key executives must collaborate to select, implement, and optimize new payment solutions?
I think this is a really important question, and for us, our executives across our leadership of the whole hospital, clinical, financial, IT-related, are all involved in part of the patient experience. We have patient experience steering committees that cover leadership of all areas. So when we're talking about protecting the patient and giving the patient a lot of options and technologies, we need the executives who are in charge of finance, which is where our revenue cycle rolls up to. We even have our clinical leaders as stakeholders. The other key people are our technology or our ITS group. They're heavily involved, and that falls under the security piece as well as the treasury, and those are in charge of our banking relationships.
Very good. Very good. All right, we're going to keep moving along. We have a few minutes left, so I want to touch on as many of the questions as we can. Dan, let me go to you on this one. What systems and applications can patient payment technologies integrate with to offer payment options throughout the care process?
No, it's a great question. I think that integrated payments is really part and parcel of what we see as a kind of overarching solution to the patient facilitation of payment process. So examples of software where you could integrate it to would be the EHR itself, practice management systems, certain types of revenue cycle management applications. We've talked about online patient portals, and then kind of this general area of patient engagement solutions, which has become kind of it's a catch-all phrase, but it's kind of a broad category now that includes things like appointment scheduling, appointment reminders. Those are now, reasonable places to ask for maybe for a pre-visit payment as a way to both collect the money and not necessarily do it in an approachable way, because you're providing a service through the reminder process, but also, just so would you like to pay $25 towards your thing? You give someone the opportunity to pay in an easy way at that time. You're going to be ahead of the curve in terms of collections. So those are the types of applications where we see integration of payments being most commonly implemented.
Very good. Sharlene, let me go to you on this one. How can hospitals handle the balance between requesting, and Art touched on this a little bit, and requiring payments? And then you have the issue of collecting payments and sending someone to collections and all these types of things. So, a lot of hospitals are not-for-profit. A lot of them have that charity element to what they do, but everyone needs to stay afloat. So how do you balance this?
Yeah, it's not easy. So we do specific training for our staff who speaks with patients either in advance via phone call or when a patient arrives for an appointment, because a lot of people are very uncomfortable with requesting money from patients, and it's much easier just to avoid it. So we have specialized training for our staff how to politely, but, get your point across that we need to collect payment. We do not require upfront payment for our services. We will bill patients after the fact, but we have more and more conversations up front trying to obtain and secure payment. At the very least, we have the conversation that they should expect a bill if we don't collect that money up front.
Yeah, it's a touchy subject. Dan?
Yeah. Yeah, I think just to kind of take it a little bit further with what Sharlene said, I think every opportunity. I don't want to sound like I want to be sensitive to the patient, obviously, but every opportunity you have to give them the ability to pay, I think is kind of a strategy that's that ultimately will be effective. That doesn't mean because it saves you from you're not really badgering them to pay. You're giving them the opportunity in a very nice way at different points in the whole care process.
And Art, in a big picture sense, and it's changing, as Sharlene mentioned, over the last 5 years, and it's changing now, but there's still an attitude among some people that healthcare is just not something they should have to pay for. So trying to get people to pay for something that they don't, either they figure it should be free or my insurance company should cover. I have insurance, so they should cover it regardless of the specifics of their plan. Is there anything hospitals can do to dispel or to battle that sentiment?
Well, I think most of the hospitals need, they need to
like Sharlene had mentioned, is to have a conversation ahead of time with our patients and the expectations, and potentially guide them through their coverages when they're booking appointments, and helping them understand that, and keeping directly away from the industry lingo language that we tend to think, as people in IT, myself included, tend to throw out acronyms, and when I'm talking to people, I have to be conscious of the fact that they have absolutely no idea what I'm talking about. And, I mean, the same translates, back into the patient conversation. I mean, I can talk to my peers and, we're rambling along, but the minute I step out into the user community, they look at me like I have 10 heads. And the same happens with the patients, I think. I think engaging them in an honest discussion and trying to explain that coverage stuff to them in a easy way to understand is a difficult conversation, because it's not easy to manage, because it's very complicated. And, when we get into the coverage stuff in our system and everything, to determine costs, it can be, even to the people that understand it, really tough. So I think the engagement of the patients and the conversation at their language level and their understanding needs to be well thought out by any healthcare industry, and help guide them along. And that's the important purposes, and not saying, well, your health insurance doesn't cover this, but we're going to do this. You have to guide them through that in a compassionate, empathetic way. And that goes a long way to the payment and the reimbursement side of things. Then they're more willing to do that. And like we mentioned earlier, setting up ahead of time the payment plans and offering that ahead of time and say, look, here's your 3 options, one lump sum, and then these other 3 options down here you can have, in order to understand that. And I think another real important part of it is part of that discussion is understanding their financial position. Safety net hospitals versus for-profit, the clientele that you have varies from, just putting milk and bread on the table to the higher end of the spectrum. That really doesn't matter. Understanding where your patient fits into that demographic, can tailor that conversation and help them along.
Excellent, excellent comments. We're going to go with Dan for our last question, and then we're going to wrap it here. So, Dan, not to be dire, but what's going to happen to health systems that don't adjust, and what does that mean? First of all, Dan, give me an idea of what it means not to adjust. What are the health systems doing now? And just give me a scenario for someone who's not going to change, and what is that going to mean?
Well, I think the definition of not going to change really just means kind of keeping things the status quo, where they've been before, and not, in effect, not doing any of the things we've talked about in terms of education of patients, patient engagement, offering opportunities to pay along the care journey. In terms of the consequences, I read there was a stunning article in Becker's in late November of last year. The article was entitled "Healthcare Bankruptcies More Than Triple in 2017." And the first line of that article said, "Regulatory changes, the rise of high deductible health plans, and advances in technology are a few of the factors that have taken a toll on healthcare companies' finances." So I want to put a plug out to the provider side here, because we've talked a lot about the patients and how patients need to be approached carefully and fairly in order to request payment. But in terms of when you're in the healthcare provider organization and you're implementing these new types of payments, new types of payment opportunities or payment processes, there may be some institutional pushback on that, whether that comes from security, compliance, finance, treasury, wherever it comes from. I think one thing you can be armed with is this is not an option. I mean, this is a necessity. The environment has changed that much. I read a statistic recently that something like almost 20% of hospital HR, on average, is now borne by patients. That's an incredible number. And worse than that, the question with patient payments is different than payer payments, because the revenue cycle management challenge with payers was always not so much if you get paid, but when. With patients, there's a question of will you get paid at all? So
right.
it's so critical, and it's critical to be able to keep the hospital in a fiscally a survivable situation in order to continue to be able to do its job and provide care. So it's very, very important. It's more important than I think a lot of people realize.
All right, well, that's about all we had time for today. When you close out your WebEx window, you're going to be taken to a post-event survey. If you could take a moment to answer that, we'd appreciate it. For those of you with continuing education interests in today's event, attending our events gets you one CEU for the CHIME CHCIO certification program. And if you need a certificate of attendance for another CEU program, you can use the final slide in this deck. You'll receive an email when this archive of this event has been posted to our YouTube channel. If you'd like us to produce a webinar on the topic of your choice, you can contact Nancy Wilcox from our team, and you can go to our website to view our upcoming schedule. So with that, I want to thank our panel, Sharlene, Seidman, Art Ream, and Dan Berger. I want to thank our sponsor, AxiaMed, and I want to thank you, our attendees. Everybody have a wonderful day. Thank you.